call this meeting to order. I must say, coming in here today, there was activity, there was discussion. It's starting to feel like a regular parliament again, so it's a very, very nice sign. Welcome to meeting number 8 of the House of Commons Standing Committee on Public Accounts, pursuant to Standing Order 108-3G. The committee is meeting today to undertake a study on Report 11, Health Resources for Indigenous Communities, Indigenous Services Canada.
Today's meeting is taking place in a hybrid form pursuant to the standing order adopted by the House on the 25th of November 2021. The members can participate in person or through the Zoom application. Deliberations will be broadcast on the House of Commons website. For your information, the web broadcast will always show the person who is speaking rather than the whole committee.
To remind all participants this meeting that screenshots or taking photos of your screen is not permitted. Compte tenu de la situation actuelle.
Given the situation of the pandemic right now and based on the recommendations for the health authorities, as well as the recommendations of the 19th of October 2021 to stay in good health and to be safe, all those who participated in their meeting in person must follow the following rules.
Enforce these health measures for the duration of the meeting, and I thank members in advance for their cooperation. To ensure an orderly meeting, I would like to outline a few rules to follow. Les députés et les témoins peuvent s'exprimer.
Members can express themselves in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen between the floor, English, or French. If you lose interpretation, please let me know immediately, and we will see that the problem is corrected so that you will able to have interpretation before we go ahead with the work. Please use the raise hand function on the platform, which you will find on your toolbar when you want to speak or if you want to alert the president.
Proceed as you usually would when the whole committee is meeting in person in a committee room. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. For those in the room, your microphone will be controlled as normal by the Proceedings and Verification Officer. When speaking, and I should probably learn this as well, please speak slowly and clearly. When you are not speaking, your mic should be on mute. Je vous rappelle que
I would like to remind you that all of the members, as well as the witnesses, must address your remarks through the chair.
Speaking list, the committee clerk and I will do the best we can to maintain consolidated order of speaking for all members, whether they are participating virtually or in person. I would now like to welcome our witnesses. And how's that, the one we're waiting on? Is it still rolling out? Still? Okay, perfect. Yeah, I'll introduce everyone. From the Officer of the Auditor General, Andrew Hayes, Deputy Auditor General. It's good to see you again, sir. Glenn Wheeler, Principal. Doreen Devine, Director. Hold on a second. I'll just say Director. Department of Indigenous Services, Christian Fox, Deputy Minister. Dr. Tom Wong, Chief Medical Officer, Chief Science Officer, and Director General. Robin Buckland, Director General and Chief Nursing Officer. Doreen Devine, did I have I have it down here, Director. Is that accurate? I don't want to miss, yes. Okay, thank you very much. You have 5 minutes to make your opening statements, and I'll go to Deputy Auditor General, Mr. Hayes. You have the floor, sir, for 5 minutes.
Thank you, Mr. Chair. We are happy to appear before your committee today to present the results of our audit of health resources for Indigenous communities. I would like to acknowledge that this hearing is taking place on the traditional unceded territory of the Algonquin and Anishinaabe people. Joining me today are Glenn Wheeler, who was the principal responsible for the audit, and Doreen Devine, the director who led the audit team. This audit focused on whether Indigenous Services Canada provided personal protective equipment, nurses, and paramedics to meet the needs of Indigenous communities and organizations during the COVID-19 pandemic. Overall, we found that Indigenous Services Canada adapted quickly to respond to the COVID-19 pandemic. During the pandemic, the department relied on the National Emergency Strategic Stockpile to supplement its own supply of protective equipment. Before the pandemic, the department was providing equipment and healthcare workers to 51 remote or isolated First Nations communities. We found that during the pandemic, the department expanded access to protective equipment to all Indigenous communities when provinces and territories were unable to meet the demand. It also expanded access to protective equipment to other individuals, such as police officers and people sick with COVID-19 or caring for a sick family member. During the first 10 months of the pandemic, the department responded to more than 1,600 requests for multiple pieces of protective equipment. We found that communities, many of which are remote, received their shipments on average within 10 days of requesting equipment. Cependant, nous avons constaté une
However, we found a number of weaknesses in the way that the department managed its own stockpile of personal protective equipment before and during the pandemic. The department did not have complete and accurate data on the stockpile's contents. We also found that the department had not followed its own approach in procuring sufficient equipment before the pandemic. As a result, it did not have enough of some types of protective equipment in its stockpile when the pandemic broke out. We also found that in relation to providing nurses and paramedics to the communities, the department streamlined its processes for hiring nurses in remote or isolated First Nations communities. In addition, the department made its contract nurses and paramedics available to all Indigenous communities to respond to additional COVID-19 health care needs. While the department took steps to increase capacity, the number of requests for extra nurses and paramedics also increased. As a result, the department was unable to meet more than half of the 963 requests that it received between March 2020 and March 2021 for extra nurses and paramedics. The pandemic aggravated pre-existing challenges in meeting nursing needs in remote or isolated First Nations communities. Several factors contributed to nursing shortages in many of these communities, including the national shortage of nurses, the challenging nature of the work, the diverse skill set required to work in remote or isolated communities, and poor housing. Mr. Chair, this concludes my opening remarks. We would be pleased to answer any questions the committee may have. Thank you.
Nos stocks de la période avant la pandémie. Nous avons ensuite examiné la rapidité avec laquelle l'équipement de protection individuelle.
Sorry, the microphone was off. Yeah. Sorry about that. To respond, we reviewed our inventory of PPE from before the pandemic. Then we looked at how quickly the PPE was being used during the first year of the pandemic. And overall, we were satisfied that we had enough PPE from the Public Health Agency of Canada to meet the needs of communities. We recognize the challenges of acquiring PPE on an international scale. We also started working with the Public Health Agency of Canada on a joint automated inventory management tool. This will give us accessible, up-to-date information on the PPE stockpile that will help us manage the emergency situations. We also started working last summer with a contractor to finish a full recount of all PPE. Then we will be updated on our inventory tracker accordingly. I'm very pleased to say that the department's inventory target has been increased from 6 months to 12 months worth of PPE in its stockpile.
Month to a 12-month supply at all times. We're also committed to conducting monthly inventory analysis so that we can be proactively managing the PPE stockpile, staying on top of trends, and anticipating any needs. And finally, we're reviewing our chain of PPE custody and disposal practices to ensure a stable inventory. La deuxième recommandation de la vérificatrice générale.
And now I would like to address the auditor's second recommendation concerning the shortages of nurses and paramedics. The report said that the department should work with remote or isolated First Nations communities to look at other ways to address the shortages of nurses and to review the nursing and paramedic support that communities receive. This is a recommendation that we're agree with. So we are collaborating with the 51 First Nations communities that we serve directly and the 29 who are managing their own nursing stations. Supported by Budget 2021, we are focusing on 3 areas: hiring new nurses, keeping them in the job, and lessons learned during the pandemic for how to incorporate
partnership with nursing leadership within the department, our Indigenous partners, and under the umbrella of the Nursing Health Human Resources Framework. We're examining how we can better recruit and retain nurses by enhancing nursing supports, by increasing access to practical nurses and nurse practitioners to augment the existing registered nurse workforce. The department has established and managed surge nursing and paramedic contracts to complement our workforce. Since April 2021, there have been over 11,000 service days of surge supports provided to help maintain essential clinical services in remote communities. We're also working to create an internal primary care nurse search service team. In time, this team will provide us with added flexibility to respond to the need for additional nursing resources. We're making improvements in areas such as customized nurse supports to resolve frontline issues related to IT, compensation, security. We're working to enhance our clinical practice supports and, of course, our continued 24/7 access to a customized nurse employee assistance program. As we all know, our frontline workforce have been working very hard under challenging circumstances throughout the pandemic. Nous remercions la vérificatrice.
We would like to thank the Auditor General for their recommendations, and we feel that the changes that we have brought forward will help. And we also believe that we can better respond to the needs in health services. Thank you very much.
Merci beaucoup. And Ms. Fox, I think I might know your father. He used to be in politics, wasn't he?
That's correct, yes.
Yeah, so, very good. Mr. Duncan, you have 6 minutes, please.
Thank you, Mr. Chair, and to our witnesses for being here today. I want to focus my round or my questions on the shortage of additional healthcare staff, as was alluded to in the opening statements. And for context, I'm proud to represent and work with the community of Akwesasne in my riding of Stormont, Dundas, South Glengarry, and actually is an example, while not being remote, it certainly speaks to the challenges of retracting and retaining healthcare staff There's a Dr. Ojisto Horn is the only full-time general practitioner at one of the clinics in Akwesasne, for an example, a community of 25,000, and works with two nurse practitioners that cover about 14,000 patients. And there was a good CBC article that came out at the beginning of the pandemic and notes to kind of getting to my question that even before the pandemic, as was alluded to in Mr. Hayes' opening comments, there were some challenges already arising before the pandemic exacerbated the challenges. Mr. Hayes, for statistics purposes, one of the things that I was just wondering is, you provide the data on the services being met or not met during the pandemic. For giving us a context, do you have, and if not, would the Deputy Minister be able to provide our committee an idea of the request for services pre-pandemic of what was met and not met to understand perhaps the volume and the percentage of success in terms of meeting those requests? Did you look at that data, and if not, can we get that?
I do not have that data on hand. The Deputy Minister might have a perspective on that, though.
To the Deputy Minister, then?
Thank you, Mr. Chair. I think in terms of the question itself, I would say that, the support that were requested in terms of surge during the pandemic were very much to complement sort of the staff, the additional requirements beyond the staff that we currently have in communities. So it would be a different type of tracking in the sense that we have a permanent workforce in various Indigenous communities across the country. So at the time of the audit, it was actually 51 communities that we managed direct services, and 28 where the service had been transferred to the Indigenous communities. At this time, we're at sort of 50 and 29 because we transferred a community in Quebec. So in terms of the needs on the ground would have been sort of assessed and met by the primary health team in community and supported by the 18 physicians that we have across the country, regional medical health officers, in addition to the staff. So, in the pandemic, what we saw is an increased demand for surge supports that would not necessarily have been common during sort of prior to that pandemic. So we could probably provide the committee with statistics on the number of clients that we saw per community, our workforce in community pre-pandemic, and our workforce in community post-pandemic. And I think that could give you an indication of the need surge during the COVID-19 pandemic, if that's helpful.
That would be. Thank you for that in the backgrounder. On the contracts being distributed, how were they advertised and what did they look like in terms of, I'm assuming you work with provincial partners, obviously Indigenous communities directly, but what more advertising has been done or promotion that has been done in that sense? And then I'll have a supplemental afterwards about what more could be done, but I'll leave it at that for the first part.
Okay, so I think I would say thank you for the question. And Mr. Chair, we employ, just to give you a sense of context, we employ 862 nurses within Indigenous Services Canada. In addition to that, at this moment in time, we have approximately 600 nurses and paramedics on our roster of contracted nurses. And so we use that roster in order to fill surge, in order to fill even the requirements within communities. So it's very much a mix of Indigenous Services Canada personnel plus surge contractors. How do we get those? We definitely do work with the province. And in fact, as you can imagine, during the COVID-19 pandemic, health human resources was a challenge across the country. And therefore, we sometimes had to compete for that health human resource capacity. And so we had to think about what are some of the creative ways that we can do to attract and retain. So working with colleges and universities, working with First Nations-led institutions like SIT to try to get that health human resource capacity in Indigenous communities. And I can speak to kind of efforts going into the future, but definitely at this point, we relied on ISK nursing staff, contract staff, and then use different ways to advertise and look for skills, and even kind of within our own group, right? We have nursing staff that are in community. We also have nursing staff within the department that are doing policy work. And so we looked at even our own workforce. We looked at the retired workforce. Could we bring people back to be able to be on contract with us, even if part-time? And the last thing I would say, we also instituted ISK Care, which was a turned around in about 2 weeks. It was a safe air transport that actually moved people from community, that facilitated safely the arrival of our HHR personnel. And so we were able to fly over 5,400 health human resources in and out of communities of those 51 communities.
Thank you very much. Over to Mr. Dong, please. You have 6 minutes.
Thank you very much, Chair. First of all, I want to take this opportunity to thank the AGO for a very timely report and recommendations. And also, I want to, thank the public servants, especially the medical officers and scientists that guide the government with their expertise and facts. That it was one of the biggest reasons why Canada was praised amongst the world as a nation with a better response to the pandemic, which we haven't seen in 100 years. So, sincerely, please convey my gratitude to all public service under your supervision. So, I want to talk about the first recommendation. The Auditor General's report specifically talked about the stockpiling of the PPEs, and I heard about managing surge supplies or surge support for the Indigenous community. So first to Deputy Hayes, can you comment on doing your findings? Was there any particular focus on the fact that these PPEs expires? There's expiry date for these PPEs. And was that a factor playing to the readiness of the department when it comes to support for Indigenous community? And I'll move to the Deputy Minister on this point as well.
Thank you very much for the question. Our findings on the stockpile, the department's stockpile, focused in on the fact that there wasn't accurate and complete information of the amounts that were in stock. Before the pandemic, there was an approach that was expected to have been followed to have the appropriate amounts in the stockpile, and we found that wasn't indeed followed. During the pandemic, we identified errors in the stockpile, whether it's from manual errors in inputting information on materials received or equipment received, or the actual contents of the stockpile. So our recommendation was focused on accuracy and completeness. We didn't comment on the expiry dates. However, as we mentioned in the PPE and medical device report, that is an important factor to be aware of as you manage a stockpile.
And so to Deputy Minister, I just want to add another layer of the domestic production manufacturing capacity, because we know that we were lack of in the very beginning of the pandemic, and adding to the expiry nature of most of the PPEs, going forward, how would the ministry better manage the stockpile of the PPEs?
Thank you very much for the question. I think that the recommendation was, well, we definitely took that on, and I think that there would be sort of two components that I would point to in terms of the department's response. The first would be around the automated tool, which is very much centered on both outbound PPE and inbound PPE, having a very good sense of the type of PPE, the supply, the quantity, where it's going. Like, to give you a sense, since the beginning of the pandemic, we have received 2,241 requests that have come into the department. Over 20 million units of PPE have been shipped. At this stage, 2,201 have been delivered. So we've got, now through this automated system and through the changes that we've done in the department, we can really track the flow of PPE that we have and be able to determine both the expiry, the gaps in supply, whether it be between gloves or sanitizers or whatever it may be. We've got a very good sense. And I think, as I noted in my remarks, that new tool and the sophistication that we've brought to our current systems and how we manage it has allowed us now to build our supply to a 12-month turnaround period. And the way that we worked with communities was that we would approve requests as they came in within 2 days, ship them right away, and the average arrival of the PPE would be within 10 days. And I should also note that we provided PPE to the 51 communities and their healthcare workers, but we did not limit our PPE stock to just those health workers. If a school called, if a police officer called, if there were needs in the community, we did everything we could to respond to that need. And that was not limited to on reserve. We actually sent PPE supply to urban Indigenous centers to be able to provide those essential support for urban Indigenous individuals who found themselves either out of community or even in very dire situations in terms of the homeless, the Indigenous homeless population. And so it was very much not just limited to that. So how does it help us going into the future? I think we've got a much better system to plan, to track, and to be able to have confidence in our ability to meet the demands as they come in.
Much.
30 seconds.
Oh, okay. I'll stay on the supply issue then. You mentioned about 10 days. Does that take into account in a pandemic setting? Every country around the world is competing for those PPEs. So in going forward in future, will we still again revisit the sort of the crisis situation in the beginning with the lack of PPEs?
I'll need a 10-second answer, please.
I think with our 12-month supply, we're much better positioned than we were pre-pandemic. And I think that we do our best to get to communities as quickly as we can, but we also have to remember that some of these communities are quite remote. So it's not like just shipping it to Toronto, it's shipping it to sometimes very isolated and remote areas. Thank you.
Thank you. Madame Sinclair Desgagnés, s'il vous plaît, vous avez 6 minutes.
Merci.
Thank you, Mr. Chair. First of all, I would like to thank the witnesses, and I would like to say, as my colleague on the opposite side said, your work is very important, and it has been so when the vulnerable populations that you work with the most vulnerable, and sometimes those are the people who really suffer the most during a pandemic such as what we have experienced. So thank you for your work. In Quebec, maybe some of you know, but when Quebec speaks to the First Nations, we speak nation to nation, and we consider the First Nations as our brothers since 1603, and so that's our history. My questions regard the strategy as of 2014, which was not applied, where the stocks were not renewed in time. So I would like to know what happened and why the strategy was not implemented. Thank you for the question. And I think that what we can recognize is that the 2014 strategy was a hybrid strategy, but we think it's very important that equipment be available, and that we deal with the Public Health Agency of Canada, and we've seen that there were shortages nationally across the country. So if we look at the 2014 model and where we are now, the changes that we have brought forward mean that you really shouldn't just look at the percentage of equipment that is being received directly from the agency, but above and beyond that, you have to look at the capacity to respond, and where there's purchases made by the department. And what's important also is to note that maybe in 2014 the measures weren't in place, and that to do a daily review now. We're able to review on a continual basis what is the stockpile, when we can better understand what we have, what we are missing, what we need. So I think, unfortunately, things were done in an ad hoc fashion, but I think that we really need to take into consideration what we experience during the pandemic and the recommendations, and this gives us an opportunity to ensure that we can move into a phase where we will be ready before the end of the fiscal year at the end of March 2022, and we'll continue to improve our methods to be able to respond to the needs now, but also in the future. Another question. We have roughly 600,000 articles that difference between what was registered and what was actually available. So that really is 600,000, almost 600,000. That's an awful lot. So you see that those are errors that were due to the process, and that those errors will not be recurring because of the new process in place. Yes, that's absolutely true, that we can better understand now what we have done and what we are doing. And I must say that the second measure that will help will be with how we're dealing with a warehouse, with our stockpile, and so that we can actually ensure that not only we have a good understanding of what is there, but that we'll be able to ensure that the management of the stockpile will be able to help us to ensure that not only we will know what we have, but we'll also be able to preserve all of the items that we have within the department. That's excellent. Mr. Chair, I have a minute left? Yes, a minute and a half. Oh, thank you. So you were talking about the plan and the tool that should be ready by the end of March 2022. Yes, we're already in March 2022. Answer, yes. We're doing testing right now, and we have two stages. We have all of the PPE that we have in the stockpile, and what's going out and what's coming in. So we have the outbound numbers, and the testing will be done before the end of the fiscal year. We're starting shortly with that. But as you know, the systems, information systems, the technology will need to be tested. We need to be able to give support when needed. So we can't just, we have to ensure that this new system is working correctly, that it is, so there will be a few upsets as it starts. So we have testing that will be starting before the end of the year. Okay, so you'll be putting things in place. Okay, thank you. I'm good. Thank you. Mr. Desjardins.
Thank you very much, Mr. Chair. And I often find these studies difficult because I've experienced in many ways, like last committee, what this work actually means in community and on the ground. And to Madam Fox, I know you've spoken quite highly about the work that's been done here, but there's tremendous gaps. And this is the work of our committee, is to identify these gaps and to ensure that you know of them. So please don't take anything I'm about to say personally, but I hope that it in fact informs your work better and we can actually ensure that lives are saved, because lives were lost. My uncle died in reserve during COVID, 15 days after a request from the community went for PPE. That is someone's responsibility. They never got the services in time. They never got what was really needed so that the community can truly protect itself. And this isn't a new story for Indigenous people. We've experienced this time and time again, whether it was TB, like during the residential schools where Canada failed to act to protect my grandmother, my uncles who died in that institution too, or if it was before that, smallpox, where it was at times deliberately brought to community. So these are the types of communities we're dealing with, communities that are trauma-informed by that experience. I remember growing up with stories from my Cookham and Musham about how scary it was when the Indian agent would come with a medicine chest and they were uncertain as to what was in it, but they're even more afraid for what wasn't in it. And many of these nations have signed treaty with Canada, asking for a guarantee for health, like the Medicine Chest Clause. The Medicine Chest Clause is something every treaty group in this country wanted to ensure that Canada understood clearly. And I've heard from Treaty 6, 7, and 8 that this clause was Canada failed to uphold its obligations to ensuring that they had the proper resourcing as per the treaty that's been guaranteed. I really appreciated my colleague from Quebec's mention about nation-to-nation relationship. I think there's a lot that Canada can learn from that framework. In my community, we didn't have that support in Alberta. We didn't have the ability to protect our elders even. And one part of this I want to mention, and I'll spread this out over a few rounds, but in particular, the report, your action plan, states something that I found was a glaring discrepancy with what the Auditor General asked for. So I'm looking at your action plan that was provided in response to the Report 11. And under page 4 of 14, there's an action item response to what the Auditor General requests to engage First Nations community in staffing processes. You and your ministry have reported that response to that action item be work with the Nursing Leadership Council and the Nursing Retention and Recruitment Steering Committee. ISC will examine its current recruitment model. Does the Deputy Minister think that's satisfactory to engaging with First Nations communities in staffing processes?
So I would start by saying that everything that we do is in partnership with Indigenous leadership across this country. And when we talk about our response to COVID, it was never just ISK nursing staff. There was always First Nations Health Pandemic Response Team. There were mobile mental health units that were First Nations led that were working side by side with our ISK nurses and physicians. There were multiple tables that were put in place, not just for the response in terms of PPE, but also in terms of vaccination, the Protecting Your Elders campaign. So I think what I would say, first, I would offer my condolences to you on the loss of your uncle. The second thing I would say is that we cannot do these hiring practices independently of our discussions with communities. And that's the goal of this department, is about health transfer of services. It's actually empowering communities to take that on. And part of there's short-term strategies to try to fill gaps, and then the important work that we're doing on long-term strategies to actually have Indigenous students in post-secondary institutions.
But Deputy Minister, I'm asking specifically on the action plan. If you can make mention on 2.1 of your action plan states that working with Nursing Leadership Council and the Nursing Retention and Recruitment Committee, why not just respond directly to the Auditor General when they say engage First Nations communities in staffing processes? Why not make that an action item?
Okay, well, maybe we can be more precise, but it is part of the action item. It is part of our talent acquisition and management. They are central to it. And it's not limited to our nursing staff. We do that even for our senior executive team. We have Indigenous leadership that are on the interview board. So absolutely, it is something that we take on board. Absolutely, it is something that we're building into our hiring practices for the department.
Thank you very much. And Chair, how much more time? 1 minute, perfect. So in regards to this consultation work, you mentioned that there was mobile working units and there was 18, you said, I think 18 and upwards of 80 staff, when in fact this country has a massive geography of Indigenous peoples. And you know as well as I do that these staff are unable to truly accommodate, especially this report, the true need for these services across the country. Would you recognize that there's a tremendous amount of work that still needs to be done to ensure that this is truly satisfactory? Because this isn't satisfactory.
So I think the 18, I think I just want to clarify, we have 862 nurses working for us. The 18 was specific to medical health officers, like Dr. Anderson in Manitoba, who we worked very closely with on the pandemic. So I want to make it clear that the 18 are really physicians. Is that enough? No. This is the network that this department has, and that network works with obviously more provincial and territorial health experts along the way. So I don't want to make it sound like it's just the 18. It's part of the network that we have within this department. These are physicians, and then those physicians also work with others. We've got nursing support, and then we've got our contract surge. Thank you.
Mr. Patzer, you have 5 minutes, please.
Thank you very much. I'm just going to start with the Auditor General's office. There's many instances throughout the report where it references the allocation of scarce resources COVID-19 interim response strategy, and it specifically references a 2%, that they would provide 2% of bulk purchases to Indigenous Services Canada. I'm just wondering, do you have any dollar amounts for what that 2% actually ended up costing in terms of actual dollar value?
I don't have numbers for that. I would mention that, of course, with the other report that we provided, we did talk about the fact that the market was very dynamic through the pandemic, and prices would have fluctuated all the way through the pandemic, including up till now.
Right, but is there does that number exist within your department? Like, do you guys have that number somewhere else that you could table it to the committee so we actually have the total dollar figure?
We wouldn't have an up-to-date or accurate dollar figure for that, given that our work was on this report and the other report was completed in early 2021. So in order to get that information, we would need to engage also with Public Services and Procurement Canada to have a more, I guess, up-to-date number.
Okay. Is that something that you think you could get and table to the committee? Like, I just think that'd be a relevant thing to have.
I will see what I can do with our people. We don't have an audit going on in Public Service Procurement in Canada right now, so I will make I'll reach out to see what we can find.
Okay, thank you. Also, just in regards to that, like we saw at the beginning of the pandemic that we sent a lot of PPE overseas. I'm just wondering, when we look at this 2% threshold, and just I guess ISC in general, were they exempt from having their PPE sent to other parts of the world, or were we able to leave that strategic stockpile in the hands of ISC?
My understanding was that, and I'm drawing back on the other report that was studied as well. My understanding is that the scarce resourcing strategy was developed at the beginning of the pandemic to make sure that there was enough capacity in both the National Emergency Strategic Stockpile, the Indigenous Services Canada stockpile, and the provincial territorial requirements. So I think that the question of what went overseas versus what was in the stockpile are different.
Okay. On page 18 of the report, you say, because of the COVID-19 pandemic, we did not visit Indigenous communities or organizations during our audit. So just to clarify, for consideration of this report, do I understand correctly that this means that you would have normally visited these communities under normal circumstances? And do you believe that some information may have been missed because of the fact that there was no physical presence on the ground in these communities?
Our normal approach would be to visit communities and to engage directly with the leaders and the elders. In this case, of course, because of the circumstances, we weren't able to do that. So there is a possibility that we didn't have the information that we would have gotten if we were able to visit these communities. However, we did see evidence in the files of consultation by the department, evidence of phone calls, Zoom calls, etc. That's not as useful in the grand scheme of things when you can go and visit, but in the circumstances, that's what we were left with.
Okay, thank you. Exhibit 11.2, I find it kind of interesting looking at the breakdown per province. We see that Manitoba received almost 800,000 masks. Just across the board, they had a much higher number of PPE sent to them as compared to, say, Saskatchewan and Ontario. And it's kind of, we look at the population of will be served by Indigenous Services Canada there. I just find when you compare it to from the population numbers to the amount of PPE sent, why did Manitoba receive such a vastly larger amount of PPE than any other province?
I might ask the Deputy Minister, or I might suggest that the Deputy Minister might be able to answer part of this question. For the purposes of our audit, we were focused on what the department did when faced with responses from the communities. Ultimately, what was happening in a particular province, whether it was the prevalence of the disease or whether it was the circumstances of distributing PPE, the access in the province, those are all different. But in our report, we did identify which were the three top provinces for the department to respond to.
And that is your time. Thank you very much. Mr. Fragascatos, you have 5 minutes, please.
Thank you very much, Chair. Thank you to our witnesses for their work and for appearing. In the report, recommendation 1161 says, and I quote here, Indigenous Services Canada should work with the 51 remote or isolated First Nations communities to consider other approaches to address the ongoing shortages of nurses in these communities and to review the nursing and paramedic support provided to all Indigenous communities to identify best practices. The department has agreed to that recommendation. My question is on the 51 First Nations and engagement. How exactly will engagement proceed? And it's a question to the Deputy Minister. Is it are communities prioritized according to a particular set of criteria? How, if so, what are those criteria? How does engagement unfold in these cases?
Thank you very much. And I should maybe specify that at the time of the audit, it was in fact 51 communities, but we have transferred the service in one case. So if I use the figure 50, it's just to show that we're at a different place now than we were, and it's actually great news in terms of the agenda for health transformation that the Quebec community has taken on. So I think in terms of how will we engage, the first thing is we engage regularly. We have nursing staff in community at all times, and therefore for the 51 communities, there's constant communications between the chief, the band council, the health directors, and so that engagement happens consistently on the needs. And then I think specific to the recruitment and the retention, I think what we want to talk to leadership about is not just about how do we actually recruit and retain, but how do we actually modernize the practice environment? What is the well-being of the workforce? How do we actually encourage members of the community to pursue a career in HHR? And what are some of the supports that are required? How do we maintain a nimble and agile search? Like, these are sometimes very, very challenging postings. They're remote, they're rural. I, over the summer, have spent some time with our nursing staff in Sandy Lake, in Pikangikum, in Norway House. So I think the strategy and the engagement has to be about not just what they need in terms of primary health care needs, but also future looking. What does the health infrastructure in the community look like? What is the path towards the talent development? And the department has emphasized health transformation, and that is about empowering communities to take on the health services for their communities. We also talk a lot about health teams. The reality is our health human professionals at times are doing work that is perhaps administrative at times, in addition to their day-to-day. How can we kind of create these teams that are paramedics, nurses, physicians, lab technicians to conduct x-rays? And how can we engage the community? When I was in Sandy Lake, the x-ray technician and the person doing the rapid test kits or the Gen Expert testing for the community was a member of the community that was hired and then embedded into that nursing team. So I think these are the types of engagements that we need to have.
Thank you very much for that. Can you tell me, Deputy Minister, throughout the report, the phrase best practices is used a number of times, talking about the need for the department to approach things with further engagement of Indigenous communities and health practitioners there as a view to coming around to establishing best practices. But best practices is never defined. I only have a minute left or so I won't put it to the Auditor General. And I think the more important question would go to the department, in fact. How is best practices defined here? Is it reflective of Indigenous principles around healthcare? Is there other ideals infused within that conception of best practices? How will the department approach best practices? What does that mean?
Thank you for the question. I think I would have sort of three thoughts on that. I think the first one, in terms of best practices, and probably the most important, is ensuring that we have culturally relevant health services to Indigenous communities. And so that means training, it means hiring Indigenous professionals to manage health services. So I think that would be sort of a best practice that I think needs to be across the country. The second piece that I would say would be around sort of innovation. We talk about, tools that can help us, IT systems that can help track PPE. But beyond that, what are some of the innovations in terms of best practices that we can adopt, right? We've got, teams that now have, connectivity where they can, if you're in northern Saskatchewan, you can connect with a physician in Regina or in Saskatoon. What type of virtual care technologies can we do? Those
and
are
Ms.
some
Fox,
of the best
I'm going to have
practices.
to leave it there. Thank you.
Okay, thank you. Sorry.
Non, ça va, pas de problème. Just
That's fine.
Madame Sinclair Desgagnés, 2 minutes 30 secondes, s'il vous plaît.
Madame Sinclair Denied, 2.5 minutes. So my question will be for the issue of the shortage of labor for the First Nations communities. I'm especially curious to know, to have read within the report, that there are different factors that led to this shortage. I know that there's the difficulty of the work itself and the diversity of the necessary skills to be able to work in these remote areas and poor housing. So can you explain how could it be that when you offer work for people who come from afar that you're not able to provide them with proper housing? Well, answer. Thank you for that question. I think that not only that we're aware of the lack of availability of adequate housing, that this affects not only the community, but of course it also affects people who come in to work, and it's not simply for the nursing staff, but it's also for police officers who are working within the community that come from outside of the communities. So this is part of the difficulties that we do have with respect to recruitment. When we come into a community, sometimes we have a housing for maybe 3 to 5 nurses, but within COVID, we had to send more staff and teams to reinforce, and in that case, there was not always housing available. So this is a problem, and the department is trying to deal with that. I think that we've invested since 2015 $1 billion in funding. So this is a reality of our human resources. We do need to think about housing, but also about safety. Thank you, Madame Fox. You said that there was an envelope that would be funding this problem. Do you have any other numbers? Do you have objectives? Do you have a plan, a calendar, an action plan that is going to take into consideration this housing problem, which is really a problem? Well, yes. We could share with you the investments that are to be coming in the next few years. There's 965 million and that will be going into the communities. We have 1,000 projects that are going ahead. There are 350. Well, thank you very much, Madame Fox. I understand that you have a lot to say, but I do need to follow the rules here.
Thank you very much, Mr. Chair, and my questions will be directed to the Deputy Minister of Indigenous Services. So just on the same line of questioning of my colleague from Quebec related to housing, this is a systemic problem that the government has been aware of for generations. Before I was even born, my father had to build his own cabin in the northern part of Alberta, and he lived there. And he lived there without clean water, and lived there without power, lived there without the basic things that many Canadians expect in a country as wealthy as the one we have. Throughout his time there, he eventually, when he started to have children, moved out of that house and attempted to get a government-sponsored house. Once he did, he already had 4 children who ended up growing up in poverty. My oldest 4 siblings, I'm one of 8. During that time, they had many sicknesses that affected the community, and housing is critical to health. Imagine if you had someone come into your house which was overcrowded, 1 bedroom, 1 bathroom, and there's 8 people, 12 people living in your house. And then one comes home sick. You're all going to get COVID. That's what happened across Indigenous communities across this country because the housing crisis is real, and it's a massive indicator. And the Auditor General even mentioned it in his statement. The Auditor General mentioned that it was one of the criteria in it on his 9th statement. The pandemic aggravated pre-existing challenges in meeting nursing needs in remote or isolated First Nations communities. Several factors contributing nursing shortages in many of these communities, including the national shortage of nurses, the challenging nature of the work, the diverse skill set required to work in remote or isolated communities, and poor housing. That's a massive issue. And if we have these year-long plans, year after year after year for the last 50, 100 years, I'm not confident that this ministry has the ability to actually fix this plan. And we need to know, and we need to get down to the bottom of where it needs to be fixed. Because I'm interested in results and making sure that this doesn't happen again. I don't want to see more kids die. And I mentioned the last committee meeting, I've seen that. And I also want to mention that in regards to PPE supply, actually, when I was working in Alberta on behalf of Indigenous groups, we had met with the former Minister of Crown Indigenous Relations, and she committed at that time to supplying isolation units for Northern Alberta communities. 0 were delivered. That wasn't in this report, though. 0 isolation units were delivered to any of the Métis settlements in Canada. Not one Métis settlement got an isolation unit. And the minister committed to that. I was on the phone with her. And people passed away. So I would like the Deputy Minister to comment.
I'm afraid the comment's going to have to wait for your next round,
Next
sir.
round.
Yes, thank you. Next up, please, Mr. Lawrence. You have 5 minutes.
Thank you, Mr. Chair. The focus of my questions will be on, I'm looking back, but hopefully I want to be helpful to the department going forward. So, according to the Auditor General's report, in 2014, the department developed a procurement plan, however, it wasn't followed. Deputy Minister Fox, could you, and I know you are a great communicator, but briefly, if possible, tell me where were the failing? Was it a failure of resources from the government? Was it a failure of department? Or where did that failure happen?
Thank you very much for the question. I think what I would say is that, and I wasn't here in 2014, but my understanding is that there was a reliance on the national emergency stockpile, and probably in terms of when you talk about the gap was probably not a thorough assessment and regular monitoring of the PPE supply and the state of the PPE that was in our possession. And I think that's what, frankly, we're moving away from to go towards this new system.
Thank you, Deputy Minister, and we'll get back there. My concern, though, is, of course, this sort of the pandemic, which, as one of the other colleagues rightfully said, it was a 1 in 100 event, but we will have other significant events that will happen in the coming years. Are you assessing your other areas? Are there other gaps that are there? Is there a need for additional government resources? If you had a wish list, were there things that for you'd like additional funding so that we don't get caught again?
I think, well, it would be that there are enormous needs within Indigenous communities. So I think that in terms of future planning, I think that we are taking the lessons of the pandemic for PPE specifically. And I think I mentioned moving from 6-month supply to 12-month supply, which allows for that buffer zone if ever we were to face a similar event. Where I think that we need to really think about is emergency management in this country. And that is not just exclusive to a health pandemic, but we faced significant challenges over the last 2 years, because not only were we facing COVID pandemic, but in addition to that, we had fires and flooding. And so this requirement for PPE and safety protocols was not limited to a community. It was also important when there were evacuations. Data, I think, is a huge area of concern in terms of well-managed health, human resources, health services.
Thank you, Deputy Minister.
Culturally relevant.
I think you just said something that I wholeheartedly agree with. I believe in many sectors of the government, and this goes back multiple governments, we haven't invested appropriately in data management. So I'm glad that there's going to be a data management involved in PPE. But is there a particular area where the government could invest more money with respect to data management, maybe with respect to climate change resilience or otherwise, specifically, that maybe you'd have the opportunity to get on the record?
Well, I think we absolutely think that data and capacity to support Indigenous leadership in this country for all areas of EM or health or economic development, I think data, capacity, and governance is key.
So with respect to the PPE, my understanding is that you were just using spreadsheets, nothing more sophisticated than spreadsheets up to this point. Are there other significant areas where we're relying on simply spreadsheets to support the data management of your department? To be clear, I don't blame you. I think this is, like I said, multi-government failures of investment for data management.
I think that in full transparency, I would have to kind of do a full review of the department. But one thing that does come top of mind is the data from our nursing stations that support communities, and having the accessibility of that data in better systems so that they can, and this is kind of beyond just the nursing station, and how it interacts with the provincial data systems. And but I do think that that's an area of modernizing our data from nursing stations would be a key priority as well.
Thank you. Those were excellent answers. I'll just finish with one short question here to keep the chair happy. Is the how much of the PPE that you are procuring or asking for is made in Canada, and how much is made by Indigenous-owned businesses?
So I would have to check on that. So 2% of what we receive would actually be procured by PSPC and by the Public Health Agency of Canada. And then we also sent funding directly to Indigenous communities to purchase their own PPE, some of which may have been Indigenous businesses. But I would also note that we have a 5% target for Indigenous procurement, and this department will be.
Your point was made. Thank you. Ms. Yip, you have 5 minutes, please.
Well, I'd like to thank Mr. Lawrence for realizing the importance of investing in data management. That's always great. I'd like to thank all the witnesses for appearing today, and welcome Dr. Wong. And my first question is to Dr. Wong. How were children, seniors, and those who were immunocompromised medically treated during the PPE and nursing shortages, such as medical care for diabetes or cancer?
Thank you very much, for the question. For all of us in the department, we have been very concerned even before the pandemic, about the most vulnerable population within, each community, whether it's First Nations, Inuit, or Métis, especially individuals, who are elders, or with diabetes, or with cardiovascular diseases. All of the individuals are at much, much higher risks, of complications from COVID. Because of that, one of the top priorities of the department, was to convince the provinces and territories, about the importance to prioritize vaccination, as well as all the public support for all other public health measures, prioritizing Indigenous peoples. And, within each community, our regions, every day supporting the regional leadership, the health directors, in order to try to make sure, to the best of their ability, to support the protection of the elders, of pregnant women, of children, and other individuals. If we don't take care of the most vulnerable, we will not, be able to come out, of the pandemic eventually, of trying to minimize, both the hospitalization as well as fatalities, in the communities. However, having said that, because of the longstanding social determinants of health, including housing, water, etc., all of those things, are contributing, to the vulnerabilities of the members in the community, and those must be addressed. Thanks.
Ms. Fox, is there, and just to stand upon Dr. Wong's answer, is there anything that can be done in the future to help these vulnerable groups should there be another crisis?
Absolutely. I think that some of the planning that's being done now in terms of during the pandemic and the lessons we've learned to date, and hopefully post-pandemic when we can really focus, I think there are going to be strategies in place in terms of how do we manage the most vulnerable. That could be everything from housing, the anti-racism and the healthcare system strategy, our post-secondary strategy. I think there's a number of issues. I think that housing is a key determinant of health, and so we have to focus on these things. But I think I would also speak to the potential of health transformation and service transformation and empowering communities by funds to allow them to take over those services. And we are seeing some examples of what health transformation can look like. We've got NAN in Northern Ontario. We've got MKO in Manitoba. We've got a group in Nova Scotia that's going to take over a proposal to take over health services and governance for 13 First Nations. I think that the empowerment of those communities will help the most vulnerable, but it's not limited to just health. If you think about early learning and...
Thank you. Sorry. Dr. Wong, despite the lifting of restrictions across the country, there continues to be a concern for outbreaks. Are there any more outbreaks in the Indigenous communities? I've heard there was one in Saskatchewan First Nation. What is being done to support them in terms of PPE and healthcare supports?
Yeah, thank you so much actually for raising this. One of my concerns, is the public, tends to actually look at, the fact that, the Omicron wave is coming down in all of Canada and in some parts of the north as well. However, that does not mean that there are no outbreaks. Every day there's a new outbreak. There's another outbreak, in this community and that community. So therefore, one size doesn't fit all. Public health measures need to commensurate with what's happening in the community. If there's a big outbreak in the community or surrounding the community, and the ICU around the community is full, that's not the time to relax public health measures. As a matter of fact, to actually redouble the efforts of both vaccination and other public health measures.
Thank you very much. I appreciate it. We're now entering our third round. This is likely going to be our last round because we have some committee business to take care of the last 15 minutes. So without further ado, Mr. Duncan, you have 5 minutes, please.
Thank you, Mr. Chair. To the Deputy Minister again, I want to follow up again on the aspect of staffing and some of the challenges that go around there. You probably don't. I always hate asking for more statistics if you don't have them, not making a work project. But you alluded before on the recruitment aspect of working from a wide variety, I'd call, of demographic angles, of trying to encourage people that have just come out of college and university, also people who are retired and possibly looking to go up for short periods of time. Do you have a breakdown of what you found most successful so far? And the reason that I'm asking is that I don't think it's for a lack of effort by the department or Indigenous communities to attract staff, but what more can we do that we're not already doing, the federal government not doing already, that we could do to bridge that gap? And again, this has been a challenge not only during the pandemic and the surge demands, but this was a challenge before and will remain, though, after COVID as well.
Thank you for the question. I should just say maybe, so we have 862 nurses, about 500, I'd say about 50% are kind of in remote and isolated communities, and about 600 of them are contracts. So what worked in terms of strategies? Ideally, we try to first ensure that people have the right training and culturally relevant experience in order to work in an Indigenous First Nations remote community. I think that's a really important. It's not just any recruitment like a provincial government would do, for instance, to do something in a hospital setting in downtown Toronto. So I think that training is a really important requirement. I think that some of the strategies, the contract nurses, is it a perfect system? Not always. However, there's a lot of people that don't necessarily want to commit to full-time employment. And so this can be a really rich way to enhance the supports and have a workforce that we can call upon. And so we did have some successes in recruiting, I think, more people through the contract. But by changing our hiring practices, actually making more efforts, not just putting a poster up, but actually seeking candidates through various channels, Indigenous networks, hospital networks, colleges and universities. We were able to hire 177 new staff that are part of this 862 now, and that's nursing and paramedics. So I think being more proactive and not just using maybe older approaches of just a job poster on a website and really kind of going after that talent. And I think that the last thing I would say is, this kind of idea that we have around surge teams that can be mobile and move to kind of crisis or needs-based could be a really interesting way where maybe you don't have to make a commitment to live in a particular area for weeks on end over year and year and year. Maybe you would like that flexibility of coming in and out of community and not necessarily staying long term. That is something that I think could have some promise as well and could help meet some needs.
For that, and just maybe my last aspect in this, when we talk about the recruitment of medical professionals that are coming out of college or university, one of the things that I know has been at a higher level when it comes to student debt and assisting, very often young people have difficulty finding employment. I think in today's labor market, it's a completely different situation. But one of the things I'm wondering in terms of an incentive, is there anything with the department, any discussions about for young people looking to pay off student debt, gaining experience, of some sort of extra incentive program of not only being paid, but paying their student debt off, perhaps at an accelerated rate, when they're working in communities that are underserviced or more rural or remote. Do you have the ability or flexibility in your department to offer that? And has there been any conversation on that when you talk about new strategies to address the shortage of, or the recruitment shortage, both pre and during the pandemic?
Thank you for that question. And I would say that during the pandemic and even in a post-pandemic sort of, conversations that we're having within teams, we are looking at innovative approaches and we are looking at ways. And I think the one that you've raised, if you think about sometimes if, you think about either teachers college or a nursing program, and let's say you go and do a service in a community for a period of time, there's nothing concrete at this stage, but I think those are some of the ideas that we're trying to focus on in terms of innovative ways. But I would say that the funding through the anti-racism and just ensuring that we have enough Indigenous youth that have a path towards post-secondary and funding that post-secondary, I think is probably the most promising route, because the talent that is within communities is what we have to develop and maximize, and that's kind of what health transformation is about. So I think from my perspective as the deputy of the department, I think if we can sort of increase the number of Indigenous students in some of these areas, and I would not limit it to just HHR, water operators, engineers, construction professionals,
Thank you, Ms. Fox. I appreciate it. Turning now to Ms. Shanahan, you have 5 minutes, please.
Thank you very much, Chair. I was very interested, actually, with the comments of one of my Conservative colleagues. I think was it Eric talking about your Akwesasne? That's in your region, and it got me thinking about Ganawage, which is technically not in my riding of Chattagay-Call, but we are very close neighbors, and they basically took over the management of their COVID-19 response, and actually had no cases for many months until, like almost everywhere, there was an outbreak. But it was very interesting to see just how independent they were in putting forward their directive. So I just want to have an idea, and I don't really want to know if they obtain PPE from Indigenous Services. That's really their business. But if they needed to obtain it, because of course they're an urban reserve, could they have obtained it? And I'm asking that, I guess, the Deputy Minister.
Yeah, yes. Thank you very much for that question. And yes, I think we, as I said, we provided PPE to communities, not just limited to the health professionals or the ISK employees or the contract nurses. We really tried to take an all-of-community approach to the PPE. So if a community would have made a request, they could definitely have gotten PPE through our distribution channels. The second thing they could have done is used ICSF money, Indigenous Community Support Funding, to purchase their own PPE if they preferred to do it that way. That was a second option that a community would have. And then, of course, we would also provide PPE to urban Indigenous centers just because of the need and the accessibility challenges they were facing with provincial and territorial government. So the answer to the question is yes, they could have and would have that channel to make that request.
Very good. And I would like to offer the balance of my time to my colleague, MP Desjarlais. S'il vous plaît.
Do I start?
Yes, please.
How much time is remaining, Chair? No, that's good. Sorry. Thank you very much, Madam Shanahan. And exactly. I do want to continue my line of questioning related to housing capacity and the isolation units that were openly promised to Indigenous nations, including the nations that I had represented at the time of during the duration of this pandemic. What was the minister's comment or the deputy minister's comments related to the housing crisis on reserves and the inability for our stockpile to accommodate situations where isolation was required?
Thank you for the question. I'll say three things. The first thing is we definitely agree that the housing challenge and overcrowding definitely had an impact throughout COVID-19, and overcrowding does present huge challenges for health. And that would be my first point. My second point would be around temporary isolation and alternative accommodations. We did provide infrastructure for temporary isolation requirements for communities. And that was also because of conversations we had with leadership that did not necessarily want to use the school gym or the school library just because of what it meant for the children in their community. And so there were some isolation units sent across the country in different, there were different types for different purposes. And that was kind of one strategy. The second was alternate accommodation outside the community. So in cases of very vulnerable populations, they were flown out to a hub, perhaps in Winnipeg, where they would be in isolation hotels where we would provide some supports. And then my final comment would be throughout the Omicron crisis, because of the spread, when it had hit a household, we had to make determinations to sometimes people would isolate at home, which meant that the supports shifted from isolation outside the home to supports within the home. And that meant food deliveries, wellness checks, and ensuring the well-being of the isolation individuals at that time. But I will say wholeheartedly that overcrowding was a challenge.
How many units, isolation units?
I will have to get that for you. I don't think I've got the exact number across the country, but I will get that to the committee for sure.
I believe that's probably time for this round.
Well, it is. Actually, in fact, Madame St-Claude Desjardins asked to switch with you. So if you want to keep going for another 3 minutes, you have the floor.
Well, thank you very much to both my colleagues, from Madam Shanahan to Natalie. I do want to continue now to speak specifically about consultation. I think consultation is one of the keystones to making sure we have strong partnerships in Canada. And I've seen good, successful partnerships. I've seen the government, in fact, do these partnerships. I've been part of some amazing partnerships, but there are some that are continue to lack. And I think this is where one of these areas exists, is within health. And I do know that it was mentioned that you had worked with some of these 51 nations. Specifically, how many of the 51 nations were consulted directly by yourself and senior members of the ministry?
So by myself, I would say, so I did a number of all chiefs meetings throughout the different COVID pandemic time periods. So for instance, I would have done the All Saskatchewan Chiefs Committee. I did the All Ontario Chiefs Committee. I did direct outreach to Cross Lake or Barons River or Shamattawa when there was a particular issue. So this has been an extremely kind of challenging situation for the entire department. So I would say that we have regional offices across the country and regional health directors that liaise directly with Band and Council. I have spent a lot of my personal time getting back to chiefs directly, speaking to them directly for them to know that they have an option at if they need some supports. But I have to empower, obviously, our regions as well to work directly with them. All 51 have been consulted. All 51 we have, regular engagement with, and even the
Sorry, I just have limited time, Deputy Minister. Sorry, I just need to ask one more question. So when you say consulting, there's a difference between discussions and consulting. Of course, consultation, that framework requires an ongoing dialogue. And I spoke to Grand Chief of Treaty 8 just last week, and they mentioned that they did not prefer the consultation scheme currently employed by the government, and that they thought it was inappropriate and it was diminishing of their nation-to-nation rights and their treaty obligations. Would you agree?
So I spoke to Treaty 8 2 nights ago, and I spent a couple of hours with them because they did have some, they did not feel that we should be engaging broadly on our health legislation. And the message that I had for the chiefs of Treaty 8 was that we want to hear from you. and we respect the treaty relationship. And you may not agree with health legislation at the end of the day. You may not want to take this path, but let's together figure out the path you do want to take. And that dialogue will be important. So they did give us a series of dates where they do want to sit down. They also want to have this conversation with the Minister of Crown Indigenous Relations, but I did hear from them directly, and I did hear their frustration.
I'm really pleased to hear that. That's really remarkable. What about the Métis Settlements consultation?
So we have ongoing conversations with the Métis settlements. We have ongoing conversations with the MNC, with the MMF. We did a lot of work with the MMF during the pandemic.
But the Métis settlements, not the MMF.
Yeah. Yeah.
Have you consulted with them?
So I have not consulted directly with the Métis settlements, no.
Thank you very much. Madame Saint-Claude Desgagnés, vous avez 2 minutes 30 secondes, s'il vous plaît.
Merci. You have 2.5 minutes, Madame. Yes, thank you very much. It's a quick question. It's a broad question, so I'd like a quick answer from Madame Fox. When you invest funds and attribute them to different groups, do you attribute them on request, or do you do it in relation to the proportion of the population? Well, we do both. We have amounts that are requested by the population. There were two sets. There was a funding, there was health funding, and there was funding for food security and the security of the community. So for both of those types of funding, we did direct funding to all communities, and above and beyond that, there was a way to access money that was based on needs, but we acted very quickly and we made the process very rapid. Question. In my numbers, I see that in 2019, Indigenous Services Canada put 7% of their resources into the First Nations of Quebec, even though they represent 11% of the First Nations in Canada. How do you explain that discrepancy? Are you talking about health, or? Well, this was globally during the pandemic period. I think maybe it's different sources of funding, but I'd have to check. There are different types of funding. There's funding that's given directly through programs to the communities, and there are also some that have a 10-year agreement to get block funding on a long-term basis, and there are also some communities that were things were changed where there was an umbrella organization that might have received the funding because they represented some of the 22 communities, so they would receive the money, and then they would be able to provide services for the community. So it really depends on the context. Yes, well, quickly, but however, that funding does always come through Indigenous Services Canada, whether it's for education or elsewhere, but could come from other departments. If you could really answer quickly, that would be helpful. There is funding from us, and there's also funding that comes from other departments. For housing, for example, it comes from another source.
To MP Patzer, please. You have 5 minutes, sir.
Right on. That's good. I have a follow-up question just for the Deputy Minister, just in regards to that Exhibit 11.2 there, in regards to why Manitoba received exponentially more PPE than all the other provinces.
Absolutely. I think that Northern Manitoba, Northern Ontario, were probably our most challenged communities in terms of outbreak. And so not only would they have received more PPE as a result of, there were communities like Norway House, for instance, or Shamattawa or Red Sucker Lake that seemed to be in a continuous mode of outbreak. We would sort of get the numbers down and numbers would go up again. So I would say that they received likely more PPE as a result of the outbreaks and the needs within the community. A lot of those communities also, would at times decide to accommodate their most vulnerable populations outside community. In Winnipeg, in Thompson, in various areas. And so there would be PPE delivered not just to the community, but also to the isolation center. So that's another reason. And then the final thing I would say is a lot of those communities also had requests for assistance. The military was in, and we needed to ensure that throughout all of those peak periods, those supports were there for not just the community members, but the staff, including the First Nations Pandemic Response Team or the AMC ambassadors, which were deployed into community support.
In paragraph 11.58, the AG notes that the department chartered dedicated air services to transport nearly 5,400 passengers from April 2020 to March 2021. Can the department share more information on this, such as the airline used and the costs associated with this program?
I can get the committee the final cost. It's actually something that's still ongoing in some parts of the country, specifically for the Sioux Lookout First Nations Health Authority communities in Northern Ontario. What I can tell you is that the decision to provide this service was in consultations with our First Nations partners, who felt that there was a risk with our health human resources flying commercially to get to and from their communities. And therefore, to minimize that risk, they suggested that charters be deployed, which we agreed with. It was also a means to not only get our health human resources into communities, but also to transport sometimes some PPE and fast track the delivery of urgent items. We did have over 5,400 HHR travel on that system and into the 51 communities. And so I think it was done in order to protect our nursing workforce, to protect communities, to ensure no disruption in travel, just in light of what was happening at airlines at that moment. And then in terms of where we're at, we do have a contract now that we can draw from should we need to resume the service, or if ever it is a requirement for either future wave or variant for the time being. So we have that possibility of extension, but we'll get you the exact figures and who the contractor was.
Yeah, and just on that last point there, who the contractor was this a sole source contract, or was this something that you put out to tender for competition? She's on mute.
Oh, go the golden rule. Sorry about that. I owe people a coffee or something, but we've spent $51 million to date. So just for your awareness, I just saw that detail in my note, and I'll turn it over to Robin Buckland just to speak to the contracting process.
Yeah, and just if you can really include Ms. Buckland, if it was sole sourced or if it was open source.
Yeah, I just don't have the details in terms of whether it was sole source or open source, but we did work with Public Service and Procurement Canada, so went through all the appropriate processes to put in place that contract. And as soon as I have it, I will give you that information if it was sole source or competitive process.
Yeah, for sure. I think that's very, very important, just to make sure that, at the end of the day, we got the right bang for the buck for the taxpayers. So. While still providing a high quality service that was clearly needed, and I think most Canadians would agree with the fact that the service provided was needed. But at the end of the day, there's when we say sole source contract, sometimes that gets people a little bit excited for certain reasons, right? So, Chair, how much time do we got?
That is it.
That is it. That's what I was thinking. So thank you.
So, Ms. Brentford, you have 5 minutes.
Thank you so much, and thank you to our expert witnesses today. It's been fascinating. I think there's no question that COVID was a great learning opportunity for all of us, and perhaps no more so than the Indigenous Services Canada Department. So I'm going to direct my questions then to Deputy Minister Fox. Now, basically, the Auditor General's report identified 2 areas of concern and improvement. The first one being PPE. That was clearly the more easily one addressed. The workforce issues are much more complicated and complex, particularly in healthcare, particularly in isolated areas like you're dealing with. I know that many employers offer isolation pay, bonuses to attract people to these remote communities. because their living conditions aren't as desirable, and of course the isolation. Does your department do that?
Hi, sorry about that. Yes, we do. And I can, we obviously have to work within our kind of collective bargaining agreements, but obviously these are challenging positions. And in terms of incentivizing our nursing staff and helping in the recruitment, we do provide some incentives, and we can provide the committee with a bit more detail on that. But I think you're right to note that these are quite challenging postings, and at times it means people need to be away from their families for 2-4 weeks, especially during the pandemic. Sometimes our nursing staff was up in remote and rural communities for a longer period of time to try to limit that back and forth, which was another personal sacrifice that they had to make to respond to the COVID-19 pandemic.
It's not just the living conditions, it's also the working conditions is the other problem. And I know that very often, like you hear about maybe only 2 nurses for an entire community, and they're carrying the whole load without backup and people kind of there to support them. So I know there's been a lot of work on digital backup and, supporting with video healthcare practitioners. Was that utilized at all so that people could maybe do a video consultation to see what was going on with a particular patient that might be more challenging?
Absolutely, absolutely. So I've personally visited some of our nursing station and seen that very equipment where you have, in an emergency room within the nursing station, there will be a 24/7 connected unit to a major hospital, so that outreach to a physician to support the nursing staff on the ground can be done. In some of the nursing stations, we've also been able to add equipment like X-ray machines, which in the past weren't there. So that just helps with medevac and reducing the burden on travel, unnecessary travel for appointments. And I do think virtual care is an area we absolutely have to look into. There are really innovative robotics technologies when it comes to virtual care in the north that I think would be really interesting to think about using more broadly in our northern communities, both Indigenous and non-Indigenous.
I agree. I mean, it's so disruptive to have to relocate patients when they're in a critical care situation away from their family support network, and we want to avoid that, not just from a cost-effective perspective, but it's obviously better care if you don't have to do that. So one thing you did address, and I think we're all aware of this, the fatigue and mental wellness of the nursing workforce is a great concern. Can you tell me how this is being addressed? What support mechanisms are in place for helping with the mental health situation of some of these overtaxed, exhausted, burned out healthcare practitioners?
Yeah, no, absolutely. And it's something that definitely keeps me up at night. I think that we've got sort of formal processes and systems in place, which is, employee assistance and a dedicated support service exclusively for our nursing staff. So not sort of common to all of our employees across the system, which I think is important. I think that we need to have regular conversations with our nurses, and that's through town halls and it's through direct contact. And I myself reach out from time to time directly to a nurse after an incident or a challenging situation, and have made sure to visit our nurses and nursing in community so I can hear from them about what goes well and what doesn't go so well. And I think that part of that mental health and wellness and those supports are going to be key. I think that, they are exhausted. So trying to find ways to have that surge capacity, which is why I talked about that mobile health surge team. When our teams are exhausted and mental health and wellness is at risk, like having the ability to replace and have people recoup. And I think that every regional executive responsible for health is having those discussions directly with our nursing staff. And I think highlighting what they do. I think when I joined this department, I did the nursing awards, which is something we do to recognize the heroic efforts of our nurses. And someone said, if you save a life, you're a hero. If you save over 100, you're a nurse. And that stuck with me because that's what they do every day. So just wanted to share that.
Thank you. That is a lovely way to end today's meeting. I want to thank everyone for appearing today. I want to thank our team for working out the initial technical bugs. Deputy Minister Fox, I should say as well, your previous minister, Dominic LeBlanc, speaks very highly of your capabilities. I did not want you to think that I was suggesting your dad's legacy in any way overshadowed how this committee viewed your work. I think you've proven that today, but I just wanted to pass on your previous minister's remarks as well. So,
thank you very much, Chair.
And again, thanks to all our witnesses for appearing and being ready to appear today. I will now close the public portion of our meeting and suspend for about 2 minutes just to give our committee members a moment before we go into in camera. Thank you again.